So in the last video, we had seen the classification and staging system of lymphomas. Now in this video, we see what are the clinical aspects. You see the physicals in Hodgkin's lymphoma. The Hodgkin lymphoma generally presents with painless, superficial, contiguous, and predictable lymph node enlargement, mostly in supradiaphragmatic region. For example, if there is lymph node enlargement in the neck, the next may be in the armpits, and then in the chest. So it's in a contiguous manner. It is usually superficial and it can involve the deeper nodes as well, but it is mostly on the supradiaphragmatic region, mostly involving the cervical nodes. It can also go below the diaphragm as well. 10 to 15% of the patient have extra nodal disease. For example, there may be involvement in the bone marrow, the lung, and the liver. 25% patient may have B symptoms, that is, patient may have fever, night sweats, or there may be weight loss. Pruritus and particularly the ethanol-induced pain in the lymph nodes is a feature of Hodgkin's lymphoma, and in some patients we may also see neurological complaints which may be because of the physical presence of the disease. For example, lymph nodes in the axilla may affect the brachial plexus, but in some patients we also see that there is some degeneration like cerebellar degeneration in patients with Hodgkin's lymphoma. And then non-Hodgkin's lymphoma depends upon what type of non-Hodgkin lymphoma symptom is dependent on that. For example, for diffuse large B-cell lymphomas, there is central or peripheral lymph node enlargement. There are symptomatic lymph node masses with extra nodules spread to lung, liver, kidney, and bone marrow. If the large B-cell lymphoma starts in extra nodal sites, it may involve the GI tract, thyroid, bone, brain, testes, kidneys, liver, breast, and spleen. So these are slightly different if it starts as a lymph node mass. But if it starts as an extra nodal mass, it may start in these different areas. 30% of patients will report B symptoms, and they will also complain of malaise and fatigue, possibly because of the accompanying anemia. Then you've got follicular lymphoma. This is subacute or chronic asymptomatic disease. The lymph nodes are usually peripheral and they are non-invasive. It doesn't cause GI or genitourinary symptoms even if present in large bulks. B symptoms are also uncommon. Then you've got marginal zone lymphoma. It may involve stomach, lung, eyes, adnexa, breast, thyroid, bowel, skin, and the symptoms are related to those organs. The disease is present in, for example, breast may produce symptoms in the breast. So it is the localization of the disease which decides the symptom. And then you got mantle cell lymphoma. 70-90% of the patients they present with advanced stage 4 disease. Bone marrow involvement and leukemic phase is common. The GI tract, spleen, Walder's ring may be involved in this mantle cell lymphoma. Then Burkitt lymphoma, tumor of the jaw or facial bone that spreads hematogenously early to kidney, the gonads, central nervous system, or meninges in endemic type of Burkitt's lymphoma. If it's a sporadic Burkitt's lymphoma, it presents as a bulky disease which involves stomach, cecum, or small intestine. There is associated ascites. The involvement of the kidneys, gonads, CNS, or meninges is common as well. And then we've got immunodeficiency related Burkitt's lymphoma. It presents with lymph node enlargement but can also involve the bone marrow, CNS, or meninges, and rarely may present with leukemic phase. So these are the different presentations of different varieties of lymphomas. The Hodgkin lymphomas, they present slightly different as compared to non-Hodgkin lymphoma, in which in addition to the node, the symptoms may be related to the involvement of the organs. Now for the evaluation of lymphoma, we can have LDH. The higher the tumor burden, the LDH is high. We can go for CBC, a comprehensive metabolic panel, uric acid. Then tissue biopsy for histopathology to decide this is what type of tumor, and then whole body PET CT scanning to stage the disease. Bone marrow biopsy may be omitted for stage 3 diffuse large B-cell lymphoma or Hodgkin's lymphoma because it does not alter the treatment, so we do not require a bone marrow in these patients. And then CSF can be done for aggressive lymphomas like diffuse large B-cell lymphomas. CNS IPI tool can be used to predict CNS relapse or progression. And then antigen specificity for B and T cell, which is decided by the receptor present, that can tell us about the different type of receptors which are present that can help us to find out what type of lymphoma is this. Treatment of Hodgkin's lymphoma. Combined modality treatment is the treatment of option. Chemotherapy with antibody drug conjugates and radiotherapy is the usual standard of care. Different combinations are used. For example, ABVD is preferred in US while the BCOP is preferred in Germany, and the Stanford 5 is again a new type of treatment combination which is being practiced in United States. Brentuximab vedotin, which is CD30 targeted antibody drug conjugate, in combination with AVD, is the first line of treatment for stage 3 or stage 4 classical Hodgkin lymphoma. So this is another treatment now for Hodgkin's lymphoma. Local radiation of the bulky disease, or if the disease persists on PET-CT after chemotherapy. So you can go for local radiotherapy. Post-treatment surveillance is usually with physicals and routine labs. Until we have a specific reason, imaging is not done. Persistent or relapse Hodgkin's lymphoma, brentuximab vedotin salvage therapy, if successful, is followed by consolidation with high-dose chemotherapy, and there may be use of autologous stem cell for rescue in some of the patients. Then for diffuse large B-cell lymphomas, the gold standard is the rituximab CHOP therapy. For localized disease, chemotherapy supplemented by the radiotherapy of the involved region, then R-mini-CHOP or R-CVP, rituximab alone in patients who got poor performance status. More intense chemo for double hit or triple hit lymphomas. These lymphomas have 2 or 3 cytogenetic abnormalities. Non-responder relapser second-line regimens include the R-ICE or R-DHAP salvage therapy followed by high-dose chemotherapy with autologous stem cell rescue. Relapse and refractory patient anti-CD19 chimeric antigen receptor T cell therapy that may be used. So we use anti-CD19 chimeric antigen receptor T cell antibody therapy. Lenalidomide or Bruton's TKI tyrosine kinase inhibitors with R-CHOP is under trial for untreated patients, and treatment reimaging by PET-CT to see the disappearance of the disease and follow up with clinicals and basic lab tests. Of follicular lymphoma. Observation for asymptomatic, no treatment is required if there are no symptoms, just follow up. Risk-benefit ratio should always be considered before starting treatment because these are chronic indolent tumors. Radiation for localized disease, rituximab for more diffuse disease, cytotoxic chemotherapy for high burden disease. So these are the treatment options. R-benda may be superior to R-CHOP in terms of progression-free survival. Maintenance rituximab after chemo usually every 30 to 60 days. That means every 1 or 2 months. And stem cell therapy or allogeneic transplantation for aggressive disease or in patients who got relapse. So patients who are asymptomatic, no treatment required. So for localized disease, radiotherapy. For more diffuse disease, rituximab, or for high burden disease, chemotherapy. Treatment of marginal zone lymphoma. For early stage gastric melanoma, for example, eradication of H. pylori may result in tumor regression or even remission in 50 to 80% of the patients. Patients with limited disease with favorable cytogenetics, H. pylori eradication is ineffective, also cured with definitive radiotherapy. Splenectomy in symptomatic splenomegaly with cytopenias improves the cell outcome. Rituximab is another treatment option which is non-surgical for such patients who got splenomegaly with symptomatic cytopenias. Treatment of mantle cell lymphoma. Less aggressive disease needs either rituximab CHOP or rituximab benda followed by maintenance rituximab. For more aggressive disease, a Nordic protocol is used. For Nordic protocol includes a maxi of R-CHOP regimen alternating with rituximab and high-dose cytarabine. Alternating hyper-CVAD with methotrexate and cytarabine is another choice. And then lenalidomide, bortezomib, and ibrutinib in patients who have got relapsed mantle cell lymphomas. So you've got lenalidomide, bortezomib, and ibrutinib. They can be used in patients who got relapsed mantle cell lymphoma. Then Burkitt's lymphoma. Burkitt lymphoma should be approached as an oncological emergency due to high proliferation rate of this tumor. R-hyper rituximab, hyper-CVAD with methotrexate and cytarabine is the treatment of choice. Then you can use rituximab, Codox, and MIVAC as a treatment for these patients, and dose-adjusted or epoch treatment is also one choice for Burkitt's lymphoma. Then peripheral T-cell lymphoma usually require monitoring. Skin-directed treatment, for example, local topical medication, prednisolone, ultraviolet therapy, or involved field radiation therapy may be, or mild systemic treatments such as retinoids may be. 18 FDG PET scanning to identify extracutaneous disease because that changes our treatment program and the prognosis of the patient as well. For the aggressive peripheral T-cell lymphomas, chemotherapy by CHOP. For nasal natural killer or T-cell lymphoma, early incorporation of radiotherapy along with chemotherapy is more important. So there should be early introduction of radiotherapy in these cases. Antibody drug conjugate Brentuximab vedotin is used for CD30 positive lymphomas. Then histone deacetylase inhibitors, romidapsin and belinostat have moderate activity against T cell lymphoma. So these are the different treatment options. So we first decide this is a Hodgkin's disease or a non-Hodgkin's disease. It's an aggressive type of tumor, it's a non-aggressive type of tumor. If this is an aggressive type of tumor, multiple aggressive treatment options are available. And for milder tumors, you just have to sometimes monitor only. So these drugs can also be combined with radiotherapy when required. So this is the treatment plan of different type of lymphomas.